I would like to start by thanking Overcare and in particular Sharon for inviting me to talk to you. It's kind of a bit strange. Usually when on the stage talking, it's usually talking to other surgeons, to chemotherapists, to genetics, and usually I'm well armed with the statistics and study. I'm passionate about surgery or chemotherapy, whatever, and I try to convince them this is the right way to treat ovarian cancer. But talking to patient is absolutely different, and I agree with Anne what she said. Absolutely forget the figures, 5-year survival, 2-year survival, it means nothing for you. The way your body dealing with cancer is absolutely different from the way other patient is dealing. And what you're reading on the internet is just the extremes of the story. So I totally agree with Anne, don't look to the internet. Over the coming 20-25 minutes, I will talk about tiny bit introduction, risk factors, high-risk patient, signs and symptoms, how we can screen for ovarian cancer, diagnosis, and treatment. So the lifetime risk of ovarian cancer, you find it 1 in 60, 1 in 70, 1 in 80, so roughly 2 out of 100 women, they will develop ovarian cancer if they live long enough. And it's a cumulative risk, which means the more you live, the higher the risk of ovarian cancer. Typically, the peak of diagnosis of ovarian cancer is around mid-60s, so between 60 to 70. It is the 7th most common cancer in women in general, and it is the 2nd most common cancer in gynae cancer. The first most common is endometrial cancer, cancer of the womb. But the good thing about the cancer of the womb, it usually presents early. Women's postmenopausal have a bit of bleeding. They go to the GP, diagnosed and treated and cured. The problem with ovarian cancer, it has no symptoms at all, like what Anne said. So we end up, more than 80% of patients diagnosed stage 3 or stage 4, which result on a high mortality rate. And this is why it is the first leading cause of death in gynae cancer, and the 4th leading cause of death in all cancers. And we believe early diagnosis, it may improve survival. If you look to staging, it's always confusing me as a medical student, and I'm sure it confuses you as a patient, but simply stage 1, when the disease is confined to the organ, any organ on our body, ovary, cervix, uterus, bowel, wherever. So stage 1 when it's confined to that organ, stage 2 when it is just nearby, stage 3 just advance a little bit more, and stage 4 when it's everywhere in the body. So if you look here, this is, do you have your marker, Michael? Thank you very much. It doesn't work. Okay, anyhow. So this is in the middle is the uterus, and each side you see the ovary with the yellow things on it, which is the cancer, and the fallopian tube. So with stage 1, the cancer is confined either to one ovary or the 2 ovaries. With the stage 2, it has spread beyond to the womb, to the fallopian tube, to the side of the pelvis, or to the lower bit of the bowel, what we called the rectum. That's stage 2. Stage 3, the one on the left-hand side, where you have a disease on the upper part of the bowel, on the stomach, on the surface of the liver, or on the diaphragm. And stage 4 is when you have the disease within the liver or in the lung or outside anywhere else. And I'll just show you a little video clip which may explain things a little bit more. I always find difficult when the patient in my clinic to explain to them what omentum means and what peritoneum means. So maybe when you see the video clip, it means a little bit more for you. So this is a laparoscopy. So down here is, can you hear me? Yes. Down here is the head, and up there is the pelvis. Here's the left, and there's the right. So the yellow stuff you see here, this is what we call the omentum. And you see it's down in the pelvis, so just sitting over the ovaries. The glittery thing, this is the peritoneum. So it's like a clean film lining our tummy from inside. So our tummy is like a big bag full with all this stuff, with the omentum, and underneath that little big tube there, that is the large bowel. And at this stage, we usually put the head of the patient down, so all this stuff, it moves from the pelvis towards the upper part of the tummy. And just to appreciate, is that okay to see, or? Yeah. You sure? Yeah. So you see how this is the womb here, and that is the ovary. You see how close the ovary to the bowel. And this is why it's not wonder that most of the women with ovarian cancer, when they present to us, they present at late stage. That is the womb, that is the ovary, and that's the fallopian tube. and that is here the lower bit of the bowel, which we call the rectum or the sigmoid. So when you have a disease on the ovary, and usually what I'm pointing there is the surface of the ovary, most of the cases the cancer starts on the surface of the ovary. So it's not uncommon to find that cancer spread anywhere else. It's spread to the tube, that is the fimbrial end of the fallopian tube, or spread to the bowel, or spread anywhere else. Just imagine a big bag full with the ovaries and other stuff. So when you have disease there, that's how looks the normal ovary on the other side. On the left side, what I'm lifting there is the tube, and the white structure there is how the normal ovary look. By the way, that cyst on the right ovary, it's a benign, it's not a cancerous, but just to show you how things looks like inside. But it show you really how all this stuff is close, and it show you why ovarian cancer usually present in a very late stage. If we move to the side wall of the pelvis there, we see the appendix, and again, see how the appendix, that little tubular structure, and this is why it's part of the surgery. Going high up in the tummy, you see the liver at the side, that's the brownish things, and in the stomach, which is full of air, and keep going there, you see the spleen and the end of the omentum. And this is kind of sort of things that we need to remove at the time of the surgery, because any of these structures could be at risk of cancer spreading there very, very easily. Now, how are we doing in Ireland in terms of the cancer? As I said, it is the leading cause of death from gynae cancer, and it's silent killer of the woman. If we compare ourselves to other EU countries, we see we are there on the red line. We're not doing well. We are the worst in terms of outcome of ovarian cancer. I'm sorry, I have to say it, but we are the worst. If you live in Italy or France, your chance of dying, if you live in Ireland to compare to France, is double. This is case per 1,000 mortality rate. So it's 4 in France or Italy, but it is 8 in Ireland. Is this due to Irish women is different from French women or Italian women? Could be Mediterranean, nice, sun, etc. But I don't believe so. You know, in France, if you have symptoms, you jump to your GB, you have a scan within a few weeks. Here, if you have symptoms, I don't know how many weeks Anne was waiting for, or Gronia, how many weeks? 18 weeks? 18 months? Walking from a GB to gastroenterologist to gynecologist. The story is totally different in France or in Italy. So this is what really, as a patient group, what we need to work on is to improve this. This is how we improve the outcome of ovarian cancer in Ireland. In terms of risk factor, if you're being white, you're more risk of having ovarian cancer, so much better to be an African rather than a Caucasian woman. If you've never been pregnant, that increases your risk. If you have an early onset of menstruation, age 11 and 12, late menopause, mid-50s, late 50s, that increases your risk. And all that related to the activity of the ovary. You know, the principle of having a cancer, in our body right now, there's some sort of damage somewhere happening in my system, but my body repair itself, so there's always tear and repair. The cancer happens when the repair it's overdone. So instead of doing 2 cells to repair a little cut in my hand, you'll have millions of cells. So it's uncontrolled growth of the cells. This is how you develop a cancer. The thing with ovulation, if you're not pregnant, you're ovulating more. If you have early menstruation, late menopause, you're ovulating more. And every month, there is a small injury on the surface of that ovary when you ovulate. And every month, that needs to be repaired. So the more that injury happens, the more that repair happens over and over and over, there will be small risk that something goes wrong, and that something is cancer. Endometriosis is a risk factor for a special type, or a unique type of ovarian cancer, something called the clear cell carcinoma and endometrioid carcinoma. Usually when we talk in these meetings about cancer, we relate to the most common type of ovarian cancer, which is the serous epithelial ovarian carcinoma. Endometrioid carcinoma and clear cell, it is rare, it accounts for 10 to 15%, is more common in Southeast Asia and Japan, but still we see a few cases here, around 10, 15 cases a year in Ireland. Family history and genetic syndromes, Mike spoke too much about BRCA and Lynch, so I'm not going to talk about them. A protective factor, have more kids. So if you have 10, it's much better than 1. I don't know if anyone is able to have 10. I'm hardly convinced my wife to have the 3rd one. I'm trying on the 4th and she's not happy. Breastfeeding is the same. If you are pregnant, your ovary is not functioning for 9 months, and then if you're breastfeeding for another 9 months, 20 months, again, your ovary is not functioning, so you protect yourself. Oral contraceptive, it works in the same way. It prevents ovulation. Tubal ligation hysterectomy, I don't know how it works. Maybe decrease blood supply to the ovary. Now, in terms of the symptoms, if I'm talking about cancer of the womb, I'll be saying the symptoms is if you have bleeding after menopause. That means endometrial cancer, I would say in 30–40% of cases. If you have lung cancer, you'll be coughing blood. If you have bowel cancer, you'll be passing blood with the bowel. But if you have ovarian cancer, really, there is no symptoms. I can say this is the symptom of ovarian cancer. And my apology if you saw this video before, but I find it a very nice video from Target Ovarian Cancer UK, and I shared with you if you can hear it. Can you? No. Do you know how to connect the? No. Can you hear it? No. Is there anything I can connect to this one? You don't know. Okay. No.
No, because obviously I talked about, I know what I missed, all the signs were there. It's just absolutely down to get older and
I'm sorry.
changing in my body anyway.
You can't hear it, can you? No, okay, so we'll leave it. But you can watch it, it's on YouTube, it's very nice, it summarizes the symptoms. So the symptoms more or less is what Anne is saying, it's non-specific, it usually is abdominal symptoms. You're not feeling well, you feel there's something wrong, decreased appetite, a bit sick, you feel full very quickly, your bowel is not regular, a bit constipated, a bit diarrhea, bladder symptoms, pressure symptoms. There's nothing specific really about it. But what it is common about it, it is persistent. Most of us will have it, I may have it today, but I don't have it for another 2–3 months. With ovarian cancer, these symptoms is usually persistent. So you almost have it on a persistent, and it's usually recurrent. It's happened today, it's happened tomorrow, it's happened next week, and it's persistent there for a few months. And it's usually a combination of symptoms. So you're not only feeling unwell, you feel unwell with bowel is not working right, you don't feel the appetite to eat, you feel your full stomach. So you have these combination of symptoms together. So my advice, if you have these symptoms, don't wait. Go to your GP. And if your GP don't listen to you, go to another GP. And if you have an access to your gynecologist, if you know your obstetrician, which usually is a gynecologist, then go and contact them and have a scan. This is the only thing really how you can improve is what Anne did. She had her scan. She wasn't happy that the result is not normal. It is abnormal, went up for laparoscopy. And even with laparoscopy, look at that. Even with the laparoscopy, the gynecologist was saying it is normal, Anne, isn't it? So even blood test, laparoscopy, and ultrasound, and we don't know there is a cancer. So if you have a symptom, just act on it. Screening, unfortunately, we don't have a screening for ovarian cancer, and I don't think we will have a screening in the near future. To have a good screening test, you need the test to be sensitive and specific, reliable, available, cheap, etc. And none of these criteria really fit with ovarian cancer. The best screening we have is the blood test, the CA-125, and the ultrasound. But when you do a screening test, the best example for that is cervical cancer, when you have a smear test. If you do a smear test every 3 years and the smear test saying it is normal, then you believe it. It is normal, and you leave it for 3 years, and you have a confidence on it. And if the smear test is saying there is something abnormal, go for colposcopy exam, then most likely there should be something and need treatment. With ovarian cancer, it's completely different. Sometimes you find CA-125 raised, but that could be something else totally, like endometriosis, inflammatory bowel disease, fibroid, etc. So sometimes it just increases your anxiety unnecessarily, and the same with ultrasound. Not every cyst on ultrasound is cancer. Indeed, the vast majority, especially in young ladies, of cysts on ultrasound is normal, because the function of the ovary is to make cysts. Like the function of my mouth and tongue to talk and eat, the function of the ovary is to make cysts. And on the same time, sometimes you do these tests, like what happened with Anne, and you reassure the patient everything is perfect, but there is cancer. Because 50% of patients with stage 1, you remember that stage 1 when the cancer is confined to the ovary, 50% of stage 1 cancer, CA-125 is normal. CA-125 is normal, and the ultrasound is also normal. And the problem is, with the screening for many years, we are looking at the ovary as the cause of ovarian cancer, but over the last 5 or 10 years, that's completely changed. Now we believe the cause of the cancer is the end of the fimbrial tube. You remember that little things of the tube? We believe this is the cause of the cancer and being transmitted to the ovary. And so we all the time, we're doing scan to the ovary, so we're looking at the wrong organs we're targeting the wrong organs in screening. We should look to the fallopian tube. And I think the biggest study in screening is something called UKC Tox. It is a huge amount of money they invest in the study, more than 200,000 women recruited. The result will be available by the end of this year. And if that study said screening is not working, then I don't think anyone will be able to have money or funding to run any study for screening. So I don't think we need to concentrate too much on screening. We need to concentrate on early diagnosis and improve the outcome for ovarian patient. With diagnosis, if you have any symptoms, you go to your GP or you come to me, to a gynecologist, and diagnosis is usually examination, blood test, and imaging. And when you go to your gynecologist, you have a full body exam. So you start with the neck to feel the lymph nodes up in the neck. It's not uncommon to have some disease up here on the nodes of the neck. You have a breast exam because, well, like what Michael said and what Anne said, breast cancer is not uncommon with ovarian cancer. 15% of patients with ovarian cancer, could be BRCA1 or BRCA2 gene, and there is a strong link between breast and ovarian cancer. Roughly in James's, we see around 140, 150 patients of ovarian cancer, and we're just doing the general exam with the breast. We diagnose between 4 to 5 cases every year with no symptoms. So you'll have a breast exam. Then we listen to the lung. You may have fluid around the lung. That is the yellow things here, which we call a pleural effusion. And sometimes we need to drain that fluid from around the lung. Number one, to improve the symptoms. Patients with ovarian cancer, sometimes they have breathing difficulties, too much fluid around the lung. And number two, to make a diagnosis of ovarian cancer. Then we examine the tummy. Then we examine the tummy and you feel for if there's any mass in the tummy. Usually if the mass is mobile and not tender, doesn't cause symptoms, this is a good sign. If the mass is fixed and tender and sore, that is usually not a good sign. But sometimes with all this big swelling, all what you may see inside is just fluid, what we call ascites. And again, sometimes we have to drain this ascites. Number one, to have a diagnosis, and number two, to improve the symptoms. And finally, we do a pelvic exam that is very similar to have a smear test with the speculum and then a digital exam. And in a good number of cases, we examine the back passage. And that will help us to make up our mind or to decide what is the best way to go forward. Is it to give chemotherapy and to shrink the tumor? Or no, we believe this big mass in the pelvis, we can remove it with no problems, and we go with the surgery. After we finish the clinical exam, you'll have a blood test. And the blood test we can divide in two groups. You'll have general blood tests for your liver, for your kidney, for a blood count. That is to help us, to plan for the surgery or for the chemotherapy. If you have a disease spread to the liver, you may find the blood test for the liver is abnormal. If you have pressure on the kidney, you may find the blood result for the kidney is abnormal, and so on and so forth. And then you have a tumor marker. The best one we have is the CA125. And again, it is the best of the worst. It is non-specific, non-sensitive, but it's the only one we have. But it's more important really for follow-up rather than a diagnosis. The other tumor marker is HE4. Sharon has a huge amount of work on it, and with the group working with the Sharon, and hopefully we get something out of that work. By FDA, it's licensed for follow-up of ovarian cancer rather than diagnosis. Up to now, all the study is not showing it's more sensitive than CA125. It could be more or less the same, but it could help us in follow-up of patients with ovarian cancer. Other tumor markers, especially in young patients, if in their 20s or 30s, they have another unique kind of cancer we call germ cell tumor. It's very different from very different from the serous cancer. And it has a different tumor marker like HCG, estradiol inhibin, and other. Once you finish examination and blood tests, you need some imaging, and the best and the easy one is the ultrasound. Ultrasound, you can do the probe on the tummy, like the pregnant ladies, and you can see the ovary. But more important, if you do the internal scan. With the internal scan, the probe is very close to the womb and the ovaries, and you can characterize these abnormal cysts a little bit more. But even with ultrasound, with the best kind ultrasound, it will be it's increase your suspicion or decrease your suspicion that this cyst is abnormal. And in the best case scenario, without mentioning any studies or any reference, you need to do 5 cases based on ultrasound only, 5 cases of five surgeries to diagnose one case of cancer. So you'll do unnecessary four surgeries for the other 4 women to diagnose one patient with cancer. If you have a high suspicion of cancer, we do a CT scan, and this is how the CT scan looks. So the patient will be sitting on a bed, and it's go through the machine. The bed will be moving in and out. That will take around 20-30 minutes. The aim of the CT scan is mainly to look if there's disease around the lungs, if there's fluid around the lungs. That will make the stage of the cancer stage 4, and that's more or less means the patient will go for chemotherapy rather than the surgery. Also, the CT scan will be looking if there is a disease around the stomach, disease on the lymph nodes, and will show us how big is the disease on the ovary. Can we remove it surgically without a problem, or we can't? Sometimes we do MR, which not all the patients, they like it, because you see the MR machine is a bit more bulky. It is like a confined space, so it's a bit noisy. But we usually ask for MR scan if we're dealing with young patients in their 20s or 30s or early 40s, and infertility is a main issue, and we want to do what we call a fertility preserving surgery. You want to remove only one tube and ovary. So we really need more detailed information about that cyst, or about that tumor in the other ovary. Is it cancerous or not cancerous? So we ask for the MR. But MR is not done routinely for ovarian cancer. But doing all of that, examinations, CT scan, MR, up to now, we cannot say this patient or that patient had a cancer. That will increase our suspicion or decrease our suspicion of cancer. The only time you know if there is a cancer or no is when taking a tissue. So tissue is the issue. Without taking a tissue from that tumor, from that mass, you'll never be able to say with confidence there's a tumor or there's no tumor. And I will explain that in a little bit more later. If we come to treatment, and to make it easy, any cancer in our body from head to toe, treatment could be one of the 3 things or the 3 things. It's radiotherapy, chemotherapy, and surgery. I think Roshni, she spoke earlier on the day about chemotherapy, so I'm not going to talk about it. Radiotherapy, it has a very, very small role in ovarian cancer, but still sometimes we use radiotherapy for ovarian cancer. So I'm going to talk mainly about the surgery. And the surgery for ovarian cancer, we may divide it into primary surgery, something called interval debulking, secondary surgery, and palliative surgery. So primary surgery is, sometimes we use this term, isn't it, Sinead? I don't know who did this, but it's very neat. Is that you? It's very neat. So we use that term, debulking, or cytoreductive. And it is unique. Up to recent years, ovarian cancer was the only cancer when the surgeon knows that he's going to do the surgery, and most likely he's not going to remove all the cancer, and this is what means debulking. So debulk, remove as much as you can, and we do it. Because we know that is working, and that's work. With other cancers, if you're not confident that you're going to remove the cancer and remove a margin around it, and that margin, it varies. For example, in vulval cancer, we need 2 centimeter margin. In colon cancer, they need 10 centimeter margin of normal tissue beyond the tumor. No surgeon do surgery. But since our famous paper presented, I think, 1974, 75 by Griffith, we know that the more you remove, the better the outcome. And that is kind of unique for ovarian cancer, but now other specialties, other surgeons, they're doing these things for the other cancers. And this is the diagram here. It's a bit it just show you with the green if you do surgery and you leave no tumor behind you. In the red, it show you if there's left a tumor around 1 centimeter, and in the blue, if you leave a tumor more than 2 centimeter. And the higher the column, the better the survival. And since early 1990s up to now, all the studies, with no exception, showing the less you leave, the better the outcome. So there's no kind of confusion about this. Maybe this is the only things we agree on it when we discuss ovarian tumor, that the less you leave inside is the better the outcome. So with the aim of primary surgery, number 1, you make a diagnosis. Remember what I said earlier, without having a tissue, you cannot make a diagnosis. Yes, CT scan could be abnormal and CA125 high up in the sky in 1,000, but still, this does not mean cancer. The only way you make a diagnosis is by taking a tissue. The second importance of the surgery, you make accurate staging, because staging is important in determining, number 1, what further treatment you need to do to have, and number 2 is the prognosis. And when the patient, they come to my clinic in James's and we discuss the surgery, I say the aim of the surgery is 2 things. Number 1 is to remove the tumor that we know in the ovary, But the second aim is to know if the cancer has spread anywhere else or no. And I'll give you an example. A young patient with a big cyst, and we removed that cyst, and there was a cancer inside that cyst, and there is no tumor anywhere else. And that will make her stage 1A, specifically 1A, and that means no need for chemotherapy. So if she had her surgery only by removing the cyst or by just having a simple hysterectomy, that will mean stage 1A, no chemotherapy, fantastic prognosis. But that patient, she had the right surgery, and she had the surgery in a gynae oncology center, which is one of the good things happening now in Ireland. So she had the full surgery with removing of the omentum and the appendix and the lymph node in the pelvis and the lymph node high up in her tummy. And there was single lymph node high up around the big vessels with a small focus of disease. So that changed her from stage 1A to stage 3A, and that simply means she needs chemotherapy. It doesn't mean worse prognosis, but it means she needs chemotherapy, and hopefully that will improve her prognosis. Because if we assume she was only stage 1A and we did not give her chemotherapy, most likely she will relapse, or definitely she will relapse, because there's still cancer there in her tummy, which will grow eventually. But by giving her chemotherapy, hopefully there's a good chance to cure her. So that's the second aim of the surgery. The third aim is to remove the bulk, remove as much as you can of the disease, and that's definitely make it easy for Roshni to give chemotherapy because there's less tumor to treat. So that is kind of the patient we see with the big swelling in the tummy. And we usually, when we do the scar, with the cesarean section, you do the scar this way, what we call bikini line, so no one see it. But with ovarian cancer, you do the scar this way, perpendicular. So when you have opened the scar, you see the tumor there in the middle. And you have no doubt, after years of experience, that what you're dealing with there is cancer. And when you remove that big tumor there, you find another tumor underneath it there. This is another patient, very slim, but with a huge mass. And here comes the awareness, what Anis said. I mean, this patient, she have this swelling growing slowly for nearly 2 years. 2 years. Now, I cannot believe that is not causing any symptoms, because I'll show you her picture before and after. This is before, and this is after. So I cannot believe, this swelling is growing there without causing any symptom, without noticing it. So sometimes, yes, we blame the health system. GB is not available, ultrasound is not available, but also the awareness and, there's something abnormal. I have to ask someone around it is important. And that's kind of the scar we do. And when we open her, this is kind of the mass we found, and with the bowel wrapped all around it. So typically with primary surgery, what we do, we remove the uterus, we remove the ovaries and the tubes, we remove the omentum, that little yellow things I showed to you early, we remove the appendix, we remove samples or all the lymph nodes from the pelvis and hide the tummy, and we take samples from that peritoneum, the clean film which line the tummy from inside. Plus minus. Plus minus means if you open there and you see these kind of pictures and it is cancer, then you have to examine the tummy thoroughly. And wherever there's a tumor, you remove it. So if the tumor on the spleen, you remove the spleen. If the tumor on the bowel, you remove the bowel and you stitch it back again together. If there's a tumor on the diaphragm, on the liver, anywhere else, you try to remove, and you try to leave 0 behind you. But to be able to do this, you need someone who is number one, expert, number two, who have the free time. Up to recently, we don't have something called gynae oncology in Ireland. We do have obstetrician and gynecologists, which means you have the consultant like me delivering babies in the middle of the night, and then supposed to go the following morning to theater and do these extensive surgery, which takes 6 to 8 hours, and have the full concentration. And that is simply not applicable. You cannot do that. If you need to do these long surgeries, 6 or 8 hours, and you have a good outcome, a good clearance, then you need to have a full night's sleep before. And this is what my patient, they ask me when they know their surgery is tomorrow. Please, Feras, have a good night, full sleep before. Seriously. But this is improving. Now we have a gynae. Now we have, 5 years ago, there was no kind of gynae oncologist. You have obstetrician and gynecologist. But for me, for example, I'm just a gynae oncologist. I don't do obstetrics. In the Mater, the guys, they're also gynae oncologists. Things in Cork, a little bit improved. They're still doing a bit of obstetrics. In Galway, they're still doing a bit of obstetrics. But things improving. 5 years ago, no pure gynae oncologist. Now we have few centers with a pure gynae oncologist. Now, again, as I said, plus minus, sometimes you remove part of the liver, part of the spleen. Sometimes you go high up in the lung and you remove the diaphragm if there's disease on the lung. And that is what they called ultra-radical surgery. We don't know if that is going really to work or not going to work. There's few randomized trial is running, and hopefully When that comes out, we will know more. But the argument against doing too much surgery, we believe if the patient had too much disease, this is related to the aggressiveness of the disease itself. That the disease is really aggressive from the start. So it doesn't matter how much work you do, it doesn't matter how many hours you spend in theater, the disease is bad, and that is what will dictate the outcome regardless what you will do. I don't know if this is the outcome or no. There's few studies running, and when the result of these studies out, hopefully we'll have a better answer. Interval debulking, this means that we see the patient initially. We believe from the scans and the examination we cannot remove most of the tumor, that we're going to leave the tumor behind us more than 2 centimeters. And then we know if this is the case, there is no point doing the surgery. So we give them chemotherapy, 3 cycles or 6 cycles, and the aim of the chemotherapy is to shrink the tumor a little bit. Then after that, we go and we do the surgery. There's a few studies there showing that doing this is not inferior to doing surgery first. It's not superior. It doesn't improve the survival. It doesn't improve the outcome, but it's not inferior. It's not less. It's the same outcome. Doing surgery first or give chemotherapy and then surgery is more or less the same. So typically, the patient we do this is if there's a disease extra-abdominal, if there's disease mainly in the lung or the pleura. If there's a bowel involvement, we used to give them chemotherapy, but this is not anymore. We can remove whatever piece of the bowel involved and we stitch it back again. If there's a disease within the liver, not on the surface of the liver, within the liver, we usually give them chemotherapy because that means stage 4. If there's too much ascites, we give them chemotherapy first. And most important is patient status. So I don't treat, or we don't treat a 95 years old patient with ovarian cancer like we treat a 45 years old. But that does not mean that being very old or very old, decline you from having treatment. Sometimes you have a patient 80 with a very, very, very good status, and you treat her like you're treating 45. So the general condition, not having diabetes, hypertension, bronchial asthma, not smoking, good nutritional status before surgery, all that is important in making the decision which way to go, chemotherapy or radiotherapy. Secondary debulking. Secondary debulking means the patient treated with surgery, had chemotherapy, she's under follow-up, and then she had a cancer coming back later. So what you do for it? You do surgery or you do chemotherapy? And I'll show you with this example. Down there, show you the month since diagnosis, and on the left-hand side, show you the CA125 level. So this patient, she presents with CA125 level, not very high, is around 90, 80, and that's kind of typical of clear cell carcinoma. Usually with serous carcinoma, you find it in 1,000. So she had her surgery, and then she had 6 cycles of chemotherapy. She was stage 3C. And after that, she lived for 29 months, 35 months, nearly 3 years with no problem. CA125 is very normal. And then around 48 months, 4 years from diagnosis, her CA125 jumped from normal to 50, 60. Still not very high. But she had a scan, and the scan here, up you see the head, down is the legs. And I don't know if I can show you this. Can you pick where's the disease? So there's a disease here. This is the liver there. And she had a small lesion on her liver there. That is the heart. That is the bladder there. So this is the only lesion she had. And she was fantastic. No hypertension, no diabetes. Very good performance status. So we decided to treat this for her. So we treated with something called microwave ablation. There's something you do it through radiology department. And then she had chemotherapy. And she responded very well. After that, she lived 66 months now with no problems, doing very well. And one night, she presented to the emergency room with faint attack. She was confused, not alert, and they wondering what's going on. Is it a stroke or something else? But CA125 was raised a little bit. They did a brain scan, and again, they found this lesion there. And that was cancer coming back again. But she's 73 months from her cancer. She's in good conditions, no other comorbidities. So we refer her to the Beaumont. They remove that tumor, give her some radiotherapy, and I mentioned early radiotherapy. It has a very limited rule. They give her radiotherapy, and she's 12 months now from that surgery, and she's doing fantastic. So cancer coming back doesn't mean always that's it, that's the end. This could be treatment. But to consider indication for surgery, now this is example I mentioned. This is the unusual. The usual when the patient recur, they usually have disease in multiple places. Usually, not in a good condition or shape to go for this massive treatment, so that is the unusual. So to consider secondary debulking surgery, you need to have extended progression-free survival, so at least 12 months with no disease from the last treatment, like this patient, first time 4 years, second time 3 years. You have to be able, when you decide to go for surgery, that you're going to remove most of the cancer, single liver lesion, single brain lesion here or there. And the patient needs to have a good performance status. As I said, if the patient is bad diabetes, not controlled hypertension, clot, DVT, you're not going to cure it for her. And the last thing I will mention is palliative surgery. Palliative surgery usually do it to improve symptoms and the quality of life. And it's usually related to problems with the bowel obstruction, patient through second line, third line, fourth line chemotherapy, and having problem with bowel obstruction. And the option you can do, you can bring a piece of the large bowel, what we call colostomy, to the skin, or a piece of the small bowel called ileostomy, or you can just put a tube through the stomach called gastrostomy tube. The problem with these surgeries, it's very high morbid and high mortality. And if you decide with these surgeries, usually the patient is already through second, third, or even fourth line of chemotherapy. Surgery is not an option, so usually survival is a matter of weeks rather than months. So you need to have a detailed discussion with the patient and the family. What's the aim of doing all of this? And I think that is the end of it. Thank you very much.